I'm John Strum, and this is Real Talk MS. It's August 25th, and we have a lot to talk about. When we talk about cognitive function that can be affected by MS, we could be talking about several different things, including processing speed, memory, or the mental skills that we use to plan, focus, organize, and make decisions. This week, we're talking about the steps people living with MS can take to manage and even improve their cognitive function. Joining me is one of the leading researchers and experts in how people with MS can best function day to day. Clinical psychologist and professor in the Department of Physical Medicine and Rehabilitation at the University of Michigan, Dr. Anna Kratz. But before we get to my conversation with Dr. Kratz, there are a few other things that you should know about. Since the 1990s, multiple sclerosis has been organized into three very familiar clinical categories: relapsing remitting, secondary progressive, and primary progressive. And since the 1990s, these labels have guided virtually everything that has to do with MS, including clinical trials, insurance approvals, and treatment choices. They've also defined the way people living with MS understand their own disease. Now, if you're a regular listener, you've probably heard me rant about the fact that between the 1990s and today, scientists have learned a lot more about MS. And we've reached a point where the labels we've always used to describe MS have stopped working for us. Now, a landmark paper published by a working group on behalf of the International Advisory Committee on Clinical Trials in Multiple Sclerosis makes the case that these clinical descriptors are increasingly out of step with modern biology, and it's time to build a new, biologically informed framework to describe MS. This is an important topic that will ultimately affect everyone in the MS community. And before we get into it, for the sake of transparency, I want to let you know that I'm a member of the working group that wrote this paper, and you'll see my name listed as a co-author. The central issue highlighted in the paper is that MS is not a collection of separate conditions. It's a complex immune-mediated disease where inflammation, demyelination, axonal injury and neuronal loss, and tissue repair can all be happening at the same time. Because these processes occur at different intensities in different people, two individuals who may have the exact same clinical label for their MS might have completely different biological drivers operating under the surface. Individuals diagnosed as relapsing remitting MS may feel stable while their MS is technically in remission. But focal inflammatory damage or silent neurodegeneration can continue accumulating and go completely unnoticed between relapses. And the transition from relapsing to secondary progressive MS happens gradually, and today it can only be identified retrospectively, that is, once it's already happened. In clinical practice, pinpointing that exact moment someone shifts from relapsing remitting to secondary progressive MS is extremely difficult to define. And when it comes to primary progressive MS, now this label identifies people whose disability worsens from the very onset of MS. There are no so-called remissions, but it doesn't represent a single specific biological pathway. So rather than defining MS as a fixed sequence of static stages, our working group has proposed moving toward dynamic, multidimensional descriptors that are updated over time as things change. The long-term vision is to create a living biological profile for each individual by tracking continuously updated dimensions, including active inflammatory activity, and that includes both clinical relapses and subclinical MRI lesions. It includes tracking progression independent of relapse activity, or PIRA, and the underlying neurodegeneration that goes with it. It means tracking fluid biomarkers, including markers of axonal injury and glial activation. and the individual's overall degree of neurological impairment and their response to treatment. Now, just to be clear, the traditional terms we use today to describe MS aren't disappearing overnight. These terms are still important and necessary for everyday communication and for interpreting decades of clinical trial data. Instead, the proposed framework is designed to evolve. Clinical labels will increasingly be supplemented with biological measurements, and new descriptors or biomarkers would have to first be validated and standardized across clinics worldwide. And any new system would have to remain practical. It would have to be clearly understandable not only for clinicians but for patients as well. And it would have to be directly useful for improving treatment decisions so we're not just swapping one set of rigid classifications for another. The ultimate goal of this roadmap is precision medicine, bringing clinical language into alignment with actual disease biology. By moving toward a dynamic living profile, clinicians will catch disease activity earlier. They'll be in a position to intervene with greater precision and tailor therapies to what is truly happening in the central nervous system of the person standing in front of them. I'll also mention that from the beginning, this work has involved people affected by MS, and that will continue as this roadmap continues to be defined and disseminated. Now, this is going to be a marathon, perhaps an ultra-marathon, certainly not a sprint. So you can be sure we'll continue talking about this important next step into the future. Meanwhile, if you'd like to review this paper, you'll find a link in today's show notes. When someone with relapsing remitting MS is on a disease-modifying therapy and they undergo their annual MRI exam, a new, enlarging, or contrast-enhancing lesion might appear on that MRI scan. And that can happen even when that person hasn't had a recent relapse or experienced any noticeable worsening of their symptoms. And because there are no immediate outward signs, these are called clinically silent lesions. In fact, a single lesion, which accounts for about 40% of all breakthrough MRI activity, is often labeled minimal evidence of disease activity, and clinical guidelines don't recommend any escalation in treatment. Well, the results of a large international study suggest that finding even a single silent lesion on an MRI could be a clear signal to consider stepping up to a higher efficacy disease-modifying therapy. Now, in this study, researchers analyzed real-world data from more than 10,000 adults with relapsing remitting MS across 26 different countries between the years 2007 and 2025, using the global MS-based neuroimmunology registry. And here's what the numbers revealed over approximately 2 years of follow-up. Compared to having 0 silent lesions, having just 1 silent lesion was linked to a 59% higher risk of a future relapse. And for those people with multiple silent lesions, that risk jumps to 94%. The adjusted risk of confirmed disability worsening was 35% higher in people with a single silent lesion and 42% higher for those with multiple silent lesions. Now, the researchers then ran an emulated clinical trial using data from 2,264 participants taking platform or moderate efficacy DMTs to evaluate what happens when treatment is escalated after silent lesions appear. They found that patients who escalated to a moderate or high efficacy DMT within 6 months of detecting at least 1 silent lesion cut their 4-year relapse risk by more than half compared to those patients who waited for an actual clinical event like a relapse before escalating. And this benefit held true whether someone had developed 1 silent lesion or multiple silent lesions. However, early escalation to a high-efficacy DMT did not significantly reduce the risk of confirmed disability worsening during that 2-year follow-up window. Now, the researchers noted that this could be due to the relatively short follow-up period or a low overall rate of disability worsening, or the fact that current DMTs target acute central nervous system inflammation rather than the drivers of progressive neurodegeneration. The researchers concluded that the results of their study challenged the concept of what's considered to be quote-unquote tolerable minimal disease activity on routine imaging. So, if you're taking a low or moderate efficacy disease-modifying therapy, and your routine MRI shows even one new silent lesion, this is a meaningful conversation to have with your healthcare team. While risks and benefits associated with any DMT should always be weighed carefully, this study suggests that you shouldn't necessarily wait to experience a relapse before considering a switch to a stronger treatment. And if you'd like to review the details of this study, you'll find that link in today's show notes. If you're living with relapsing remitting MS, you're likely used to the typical routine. You get your regular MRI scans, and your neurologist looks for new or active lesions. And if the scan looks stable and you haven't had a recent symptom flare or relapse, you breathe a sigh of relief. But many people living with MS know all too well that how they feel cognitively doesn't always align with what those standard lesion counts show. As we just discussed in the last segment, there can be silent progression taking place behind the scenes. A fascinating new study out of Europe is shedding light on exactly what may be happening. Researchers have identified two specific brain MRI markers that can predict cognitive decline in early relapsing remitting MS with roughly 80% accuracy, even when there are absolutely no new lesions or physical relapses. To understand this breakthrough, we have to talk about what some scientists are calling PERMA, or progression independent of relapse and MRI activity. This describes low-grade chronic inflammation that slowly damages nerve fibers over time, but completely flies under the radar of our standard tracking tools. By following 87 newly diagnosed relapsing remitting patients for over 6 years, researchers discovered that nearly 2/3 experienced meaningful cognitive decline, and for 80% of those people, that decline happened without a single clinical relapse or a single new lesion. When the research team looked closely at advanced imaging, two culprits stood out. First, they identified paramagnetic rim lesions, or pearls. You can think of these as active borders. While the center of an old lesion might look quiet, a paramagnetic rim means inflammation is actively simmering around the edges, slowly expanding and eating away at myelin. Patients facing cognitive decline had a significantly higher number of these paramagnetic rim lesions. Then the researchers identified choroid plexus enlargement. Now, the choroid plexus is an important network of blood vessels that produces the fluid surrounding your brain and spinal cord. When it gets enlarged, it acts like an open highway, letting traffic lanes of damaging immune cells flood straight into the central nervous system. This study found a direct link between increased choroid plexus volume and worsening cognitive function. And here's why these discoveries are so important. Historically, cognitive impairment in MS has often been looked at as a static, late-stage symptom. This study completely refutes that. It proves that cognitive changes are an active window into the earliest, quietest moving parts of MS. If clinicians can spot these two hidden markers right at the time of diagnosis, it changes the entire treatment playbook. Instead of waiting for brain fog or memory gaps to disrupt your daily life, your medical team can proactively step in. This means doctors can use these indicators to bypass milder foundational treatments and reach directly for highly effective, high-efficacy therapies designed to aggressively put out those inflammatory fires before permanent myeloid damage occurs. The big takeaway from this study is that no new lesions doesn't automatically mean your MS is completely asleep. If you or a loved one are noticing changes in memory, processing speed, or focus, even if your doctor tells you your standard MRI looks completely unchanged, you can speak up. Ask your neurologist about advanced imaging markers like paramagnetic rims. Your cognitive health is every bit as critical as your physical mobility, and catching these silent signs early is your best strategy in maintaining your quality of life. If you'd like to review the details of this study, you'll find that link in today's show notes. And while we're talking about preserving cognitive function, it feels like the perfect time to bring in our guest, who works at the forefront of developing new ways to do exactly that. In a moment, we'll meet Dr. Anna Kratz. Dr. Anna Kratz is a clinical psychologist and professor in the Department of Physical Medicine and Rehabilitation at the University of Michigan. Dr. Kratz's work focuses on understanding how people living with chronic symptoms of MS can best function day to day. And today, we're talking about cognitive function. Welcome back to the podcast, Dr. Kratz.
Thanks for having me, John.
When we talk about cognitive function in MS, we're looking at a wide range of mental abilities. What are the specific cognitive domains like processing speed, memory, or executive function that are most commonly affected by MS?
Yeah, this is a very good question. And the answer I'll give is one that is familiar to people with MS. And it's that, um, you know, what's common for everyone may not be your situation. So there are, it's very individual what aspects of cognition are affected for any person. But I will say that research has been done to sort of find out what's most commonly affected. And it seems to be, especially in the areas of processing speed, so that is how fast you're able to think, how fast your brain works, different aspects of memory. So this might be memory for new words, or learning new words, memory for things you've seen, memory for experiences you've had, as well as working memory, which is the kind of memory where you have to hold some information in mind and sort of work on that. So maybe remembering two numbers and then adding them together, that's working memory. And then also executive functioning, what we call executive functioning. So this is kind of higher, more complex types of cognitive functioning. This might be things like planning out your day or making decisions or switching between different tasks kind of at the same time. So that flexibility can be really affected in people with MS.
Do we know why MS targets these different cognitive domains?
Well, it's a little bit unclear. MS can be associated with brain changes in both the white matter, so that's the cells in the brain that kind of connect and transmit signals. And in MS, white matter is often the focus. It's often where the myelin is actually being damaged, as well as the gray matter. So when you think about a brain, people think of it as maybe this gray organ. But it's a little bit unclear about exactly what is how MS is affecting cognitive function. One of the things I'm really interested in looking at is how symptoms that are related to MS, so things like pain, fatigue, depressed mood, anxiety, those sorts of things are affecting cognitive function. When you are depressed or have pain, your cognitive function tends to be a little more compromised. And then there are behaviors that are affected in MS, right? So sleep problems are very common in MS. That includes just kind of poor sleep quality, as well as obstructive sleep apnea and central sleep apnea. So there's all these kinds of ways that MS can affect cognitive functioning, both directly through changes in the body and brain, through these behaviors, and through the experience of new symptoms that might be impacting cognition.
Many people with MS report that their cognitive abilities can fluctuate, sometimes pretty wildly, from morning to night. Can you explain how your lab's use of real-time smartphone-based tracking helps create a more complete picture of these daily ups and downs compared to a one-time test in a doctor's office?
Yeah, thank you for asking about this. I get excited talking about our real-time data collection on real-time MS. Um, so we use smartphone apps that administer these very brief and kind of easy to complete cognitive tests. And this is in contrast to what many people with MS experience when they get their cognition tested, right? They might go into a very quiet room with with an examiner who's administering these tests. It's long, maybe you're there all day. Um, the reason we do these short tests, and we'll do them for 2 weeks at a time, 4 times a day. Believe it or not, people in our studies, people with MS, are happy to do it because I think they recognize that their cognitive function might change throughout the day. Maybe you're a little fresher in the morning, and then you have like an afternoon slump. Maybe you're a little better before bed. Um, it addresses the issues of things like if you've had a poor night of sleep. We know that sleep is really affects cognitive function. So we not only can sort of get a better assessment of cognitive change over years by taking these multiple days of little assessments and sort of averaging them, sort of washes out the effect of poor night of sleep or a day of high stress or a day of really low symptoms where maybe you're functioning at your best and sort of gives a broader snapshot versus that one day. If you go in and you've been waiting 9 months to see this neuropsychologist and get the test, and then you wake up that day and you haven't had good sleep, your pain is really bad, you get lost on the way to the clinic, you're super stressed out. Maybe that's not really what your cognitive function looks like. And it's not what your cognitive function looks like in your daily life, which is another way that it's different. Be doing it on a phone when you're in Target or, you're in your lived environment. So we think it's a much better way of assessing actual cognitive functioning for a person in their lived environment. We're just at the very beginning of sort of using these methods to try to get a better sense of cognitive functioning in people living with MS.
Well, thinking about that test you take in a doctor's office, have you found that there's a difference between what a patient feels is happening to their memory and what the standardized tests actually show?
Yes. People might be surprised to hear that what you perceive in terms of your cognitive function, so how you feel your brain is working, is not highly related to how your brain is actually working. So we have found some evidence that when we do these smartphone tests, that if you had one score in the morning and then another score in the afternoon, that you can actually say, I think my cognitive function has changed a little bit, but it's very, very subtle. And people tend to report bigger, noticeable changes in their cognition if they started off with very high cognitive function. So that's the other thing is that I always say, like, if you've had a very sharp knife and it dulls just a little bit, you notice. Versus if somebody, is not challenging themselves cognitively, they may not notice those changes as dramatically. But yeah, I think, things like depression and anxiety, especially if you're anxious about your cognitive function, can really affect your perception. And I think, slight changes in cognitive functioning that is maybe socially embarrassing. So like a lot of times we hear people complaining that like, I can't find my words, and that, that kind of social context can make that problem seem bigger than it actually is. And I think the other thing is like cognitive slip-ups happen to everybody. But I think when you are living with MS, it can be really easy to say like, oh, this is my MS. Sometimes it is, and sometimes it isn't. And I think that that's one of the reasons too, that there's like this disconnect between people's perception of their cognitive function and how their brains actually work.
You and your team have published the results of the CogDetect-MS study. Your research showed that 63% of the participants in that study were using 5 or more medications to manage their MS. Since disease modifying therapies are only part of that equation, what are the most common symptom management medications that people are taking that might quietly be piling up for someone?
Uh-huh. Yeah, so some of the medications, well, and before I go into that, I just want to thank you for bringing up the topic of multiple medications. The more medications you take, the harder it is to sort of track the interaction with those medications and any side effects that might emerge from those interactions. Um, so what we found is that, lots of people are taking medications that are not super negative in terms of cognitive function. These are things like antidepressants, which we found benefit in processing speed, so how fast your brain is working, with a specific type of antidepressant, an SSRI, that's the selective serotonin reuptake inhibitor, things like Zoloft or Lexapro. But, thankfully, some of the medications that are most detrimental to cognitive function, these are things like opioids, benzodiazepines. Those are less frequently taken in MS. And I think physicians have gotten the word that, like, a lot of these medications that are really bad for cognitive functioning um, should not be used long term. So I think that, if we had done this study 20 years ago, I think it probably would have been different, actually even 10 years ago. Um, the other thing is there are some medications that, may be used pretty frequently. These are things like gabapentin, um, or corticosteroids, that may or may not have a very strong effect on cognitive function, depending on what else you're taking and who you are. Take the example of gabapentin. Sometimes we hear complaints that, like, I just feel kind of out of it or foggy when I'm on gabapentin. But having a conversation with your doctor about all of your symptoms, and sometimes MS presents with pretty complex symptom burden. It's like, are you better with a little bit of fogginess and not the bad spasticity? So it's definitely, you should bring up your cognitive concerns with your doctor, and put them on par with whatever concerns you have, just have that conversation. If you don't express the concern, your physician won't know that, your spasticity is being managed really well, but maybe you're experiencing some new cognitive symptoms. So I think bringing it up and asking questions like, I don't know, does this medication affect cognitive function? Would it affect my cognitive function in combination with the other thing you're giving me? And just really asking a lot of questions, being curious, and initiating that conversation with your doctor.
I think you've already started to answer my next question. I'm wondering, when someone is taking a complex cocktail of drugs, like something to manage spasticity, something else for bladder issues, and then there are often pain relievers in that mix, how do these drugs interact to compound cognitive fatigue?
There's no one answer for that, right? Like, it really depends on the person and the specific medication. And you mentioned pain medications. We actually have found evidence across different populations that non-steroidal anti-inflammatory drugs, so this is Motrin or ibuprofen, that if that is a medication that works well for your pain management, that maybe that would be helpful for your, for managing both pain and not having an effect on your cognitive function. Um, on the other hand, if you're taking hydrocodone or an opioid, and that's all that's managing your pain, you might expect cognitive side effects. The interactions, though, are hard, and I think it's much easier for doctors to add new medications to address the new symptoms you're coming in with. I think it's very hard to wean people off of medications, especially if they're working for one thing, but you think they might be affecting something else. So if something is managing your pain, it might be a sort of a cost benefit analysis, and it might be a trial and error. I don't think you really know until you try to make some changes. Obviously in concert with your doctor. Would not recommend, dropping anything just because you're noticing some changes without talking to your doctor. And also know that especially when starting a new medication or changing a dose, there might be like a short-term adjustment period where your symptoms kind of go up, like maybe you feel foggy for a while when you start a new med or increase your dose. So, getting in contact with your doctor and say, I'm noticing this. Should I be concerned? Can we adjust it? And sometimes too, doctors will be able to give you a similar medication that just has a slightly different risk profile. So I think, exploring those options and having a conversation and being willing to try out some alternative plans.
Are there certain red flag combinations of medications that clinicians and patients should watch out for?
I think the highest risk medications right now, and this is really well recognized in medicine, are the benzodiazepines. So these were traditionally used mostly for anxiety, but are sometimes used for sleep disorders in MS. And again, the opioid medications are really risky. The one thing I'll bring up is that we don't really know the effects of cannabis or marijuana on cognitive function, especially in combination with any of these meds. Uh, as you probably know, marijuana is either medically or recreationally legal in many states, but is really understudied largely because of federal limitations on our ability to study it. But I think, that is sort of an unknown. I will say that in older adults, there is some evidence that some cannabis use could be beneficial, but that is very preliminary and there's real risk. So I think, the research needs to catch up to what people are doing. and and we don't have the full answer yet. Hopefully we'll know in the next few years.
You've studied how common substances like cannabis, caffeine, alcohol impact MS symptoms in real time. Caffeine, for example, it's the ultimate pick me up for MS fatigue, but your study showed it also predicts a near future spike in stress. So, what should people know about the hidden cognitive or symptomatic costs of relying on what have really become everyday substances?
Yeah. I think really paying attention, and you may even start tracking or logging your intake of certain substances and what happens to you after the fact. I know for me, I drink coffee every morning, but there's definitely a tipping point, right? Like it helps perk me up in the morning, but if I have just an extra cup, then I'm very stressed out and not functioning at my best. So I think people with MS, especially if you're sort of knowingly taking any of these substances to manage symptoms or to feel better. I know that people will sometimes drink alcohol to manage stress or pain. Um, and so it might have some benefits, but what are the downsides? And just paying attention to both the benefits and the risks and the good part of any of these substances and then the negatives is I think really important. I think caffeine is a really interesting one, right? Because like I just said, with my own life, it sort of reduces the fatigue but increases the stress. Fatigue and stress both affect cognitive function. Do you have like a potentially positive effect and a potentially negative effect? Do they just cancel out? We don't know the answer to that.
If someone is listening to this conversation and suspects that their medication regimen is making their brain fog worse, how should they initiate that conversation with their neurologist or primary care physician?
I think it depends on how severe the change is. If you're noticing big changes, I do think that calls for a very urgent message to your physician um, to suss out what's going on. I do think any kind of changes should be brought up. You may call for a special appointment to talk about them, or wait for your regular routine visits if it's more modest. You might also think about collecting some information to bring to your doctor about, patterns you see. They may be asking some additional questions about exactly what kinds of cognitive problems. So, especially if your brain feels foggy, making some documentation of it so that when you go into the appointment, you're not like, oh, I don't really remember. Um, I think the other thing to think about is that your physician might be able to screen out for some additional things that might be affecting your cognition beyond medication. One great example is sleep apnea can really affect your cognitive function. We've done some early research showing that, and um, it's sleep apnea is really underdiagnosed in MS, but it's very common. So, for instance, if you're finding that you're kind of falling asleep during the day or you're waking up feeling really unrefreshed, even though you've slept through the night, or if somebody tells you you snore a lot or stop breathing in the night, um, it's very worth asking for a sleep study from your physician to see if you have sleep apnea, how bad is it, and should it be treated? Because that is another treatment that your doctor can help you with in terms of improving your cognitive function.
Beyond looking at the impact of medications on cognitive function, your lab has also researched how people use compensatory cognitive strategies or workarounds in their daily lives. What are some of the most effective mental habits or tools you've seen patients use to successfully get around their cognitive challenges?
That's a great question. When it comes to addressing cognitive function in MS, there's really two sort of ways that we're thinking about this. All right, can we do anything to sort of improve the cognitive function? And then alternatively, can we teach people skills to sort of improve their life, even if their cognitive function doesn't change, right? Like it can't improve the cognitive function. And that's what those compensatory strategies are. And it's really remarkable the number of ways that people just naturally sort of figure out how to work around their cognitive challenges. Many people will start to use uh, ways of recording. So this might be a notebook, or now everybody has a smartphone. You can leave yourself like voice messages, that sort of thing. So really using the tools that you have at your disposal to remember things. Another big tool that is used oftentimes is day planning. So planning out the day and tracking your activities. Partly, this helps people not overdo it, helps people pace. Um, so, there's a lot of different sort of strategies people can use. I'd say that the day planning is one of the big ones. Um, and just find out what works for you. And the strategy that you will use will depend on what you're struggling with. Like, are you struggling with attention? Maybe in that case, you want to limit the amount of time you need to attend to any given thing. If you want to watch a movie, maybe break it up into sections so you don't sort of lose the thread partway through, versus memory issues where you might want to use some of these tools like a notebook, like post-it notes, like a calendar or a day planner.
Looking ahead, when you think about the future of MS rehabilitation, do you see us moving toward more personalized digital toolkits like your My MS Toolkit project to help people manage their invisible symptoms from home?
I think it's part of the answer, right? I think we are developing web-based and app-based tools that people can use to self-manage symptoms like pain, fatigue, depressed mood, etc. Uh, but I don't think it's the full story. And I think one of the real struggles with digital tools is that people don't really engage with them as much as they engage with a person. However, I do think that it can be sort of a way to fill the gap, right? There's not enough uh, healthcare providers, there's not enough physicians, psychologists, social workers, occupational therapists to go around. And There's real barriers for people. Maybe you have to drive a long way to see somebody. Maybe there are financial barriers to getting person to person care. So I do think, especially for people who are sort of really comfortable with digital technology and digital tools, these can be great. And then maybe used in combination um, with with providers. In fact, we have a study. One of my collaborators at the University of Washington, Dawn Eady, and I are working on a project to sort of look at the combination of the MyMSToolKit with a coach, so a very light touch, check in with a person, and comparing that to full on therapy with a psychologist. So I think one of the things we're doing besides developing these tools is testing how best to use them and how we can get people to have the best quality of life and to take on some of these self-management skills. Like, is it just enough to give them a website? Do they need a coach? Do they need full therapy to kind of understand? So we're testing those things out right now.
Well, I remember the first time I had you join me on the podcast, we talked about my MS Toolkit, but that's been a minute. So please remind us, where can people find my MS Toolkit today?
Yeah, great question. So it is online at www.myMSToolkit.com. I will say we are right now in the process of updating and improving the website. So stay tuned for a whole new look. It's a refresh that is much needed. And but that the version 1 of my MS Toolkit is currently available and will be for the foreseeable future.
Dr. Anna Kratz, as always, I appreciate all you do to improve the lives of people living with MS. Thanks so much for talking with me today.
Thanks for having me on, John. Good to see you.
That's going to wrap up this episode of Real Talk MS. Real Talk MS is powered by the National MS Society. And you can share this episode of the podcast by letting your friends or family members know that all they have to do is point their web browser at realtalkms.com/469. You'll find that link in today's show notes, so you can easily copy and paste it right into an email or a text. In next week's episode, you'll meet Benji Wilkins. Benji is a magician in the UK, and Benji's mom lives with MS. Like many other people, MS has had a real impact not only on her health, but on her finances. So Benji had an idea for what I have to call an epic fundraiser. I hope you're planning to join me next week, because this is a story you won't want to miss. I'm John Strum. Thanks for listening. Stay safe and make healthy choices.